I have to.
Good
morning. I have the pleasure, but it's kind of a bittersweet assignment here for me to introduce this career retrospective we're having this morning for my longtime colleague and friend, Kevin Domkowski. Kevin comes to us from the mean streets of Hamtramck, Detroit area, in the shadow of the Pole Town factory where Polish communities thrived, as you can, last name Domkowski. The oldest of a lot of brothers. You're the middle, but you act like the oldest. He was born in the wrong birth order. A lot of brothers. Before a lot of you were born, Kevin came to the University of Michigan, where he did his undergrad and master's work in natural resources. Where's that building?
They haven't bulldozed it yet. It's still there. Yeah.
Okay, all right. They might put a plaque up. So you never know.
I'm not to die.
Then off for a while doing some contract work with I'm not sure we're allowed to say very much about this. Okay, contract working for the Department of Defense primarily.
Yeah.
Where you learned all about rules. There's a lot of rules, rules for handling data, but also learned about working with a purpose, work for the objective of making something useful, creating work that would allow somebody to not just publish a paper and be happy with the results, but actually, like, let's create a useful mechanism, a useful tool, a new way of doing something. Came back to the University of Michigan to do a doctorate in informatics, and I don't even remember what the magic spark was to bring him to us, but we just really got lucky in 2000. Were you our first faculty hire?
Yeah. Yeah. He was our first PhD.
So the magic was
Gary was on your dissertation committee, and that must have been
I needed
good
a
defense.
finish.
Yep. What was that dissertation about?
It was about using the National Health and Review Survey to do immunization surveillance at a more granular level than what's done by us.
There you go. Yes.
I have Kevin's dissertation in my office,
which he reads from daily.
If anyone wants to see Kevin's dissertation, I was going to bring it. I just forgot. I read
it. Is it under glass?
Huh?
Is it under glass? Or you just have it laid
on? No, but it is in hardcover.
Okay.
Yeah, it's tattered and worn because of the references.
Yeah, and the tear stains from the beauty of it. It's in my office if anyone wants to see it.
So back at the very beginning, you came aboard with us, and it really was so critical for our trajectory, particularly opening up our work with the state. So Kevin became one of the key players in our work with Medicaid, what was then called the Department of Community Health, including the immunization branch, but also opening up doors to working with chronic disease epi around improving detection and identification of kids with asthma so they could be prioritized for additional care. And then he's going to take it from there and tell you about all this stuff. The things I want to mention are from having been on the same hallway, around the corner, on a lot of meetings with you for 25 years. Colleagues don't get any better than this.
Amen.
They really don't. If you're lucky enough to have Kevin as your supervisor or your mentor or your co-investigator, or bump into him in the hallway, he's the same person. He's interested in your life, how you're doing, as well as your family. He wants to know where you came from. He says what he means, usually a much nicer way than I would, but but like you're gonna get honest feedback from Kevin. But he's gonna do it with your best interests at heart. He keeps his commitments. If he says he's gonna do something, he's going to do it. He's a lot of fun. And he really intends for his work to be meaningful and to help people do their jobs better, help people receive the services that they need, help the system work better. He really, truly does. Remember our original logo, making a difference in the lives of children? That's who Kevin is. And I will miss him terribly, but I'm glad that we have this little walk through memory lane that you're going to do with us. So please join me in welcoming but thanking Kevin.
Thank you for that career retrospective. And are there any questions? Hey, I mean, that's pretty amazing. So, all right, Eduardo, I'm gonna have to get your assistance out of the gate here. Oh, my clicker is not clicking. All right, well, let's. Is it under warranty? Can we get it?
No, this one is, but I just fixed it, so there you go.
All right, she was good. Perfect. So to round out that spectacular introduction, thank you, Sarah, for that. And I should say thanks to Sarah here for taking a gamble. So 25 years. So most of you have not been here around for that time. So I'm going to try to compress that period of time as best as I can into three topic areas. Primarily immunization registries we'll talk about this morning. Switch over to chronic disease surveillance, did a lot of work using administrative claims and some. If we have time left, I'll talk a little bit about some of the synergies. Before I go on, a couple things I want to beg and apologize for. I beg your mercy. It's going to be a very high altitude tour. Can't get into the lots of details. So if you're looking for p-values and lots of methods, whatever, I've got citations through this for the papers, so you can rush back to your desk and look up the papers, read them today. But we're not going to get into lots and lots of details just in the interest of time. And so before I go any further, I will thank you all. This work that I'll be presenting today, little snippets of it, it's not my work alone, it's our work. That's an important part of it. So thank you. So let's start with immunization registries. And to begin, let's start at the beginning. There is really no other event that really caused immunization registries to come into their own in our country, which other than the measles outbreak of 1989 through 1991. We had a tremendous number of cases, an upsurge in measles cases for many years, many decades. We had very quiet, sort of little bumps in measles cases here and there, but for the most part, it was very stable. In '89, we had a major uptick, over 55,000 cases over this 3-year period. A terrible increase in hospitalizations. Children particularly were affected. 46 children in the United States died from measles, which was like unthinkable. And most of these cases were determined after the fact to be unvaccinated children. So needless to say, this was viewed as a major public health failure. It was in fact an outrage. Really, people were just like totally upset by this, as you can imagine. So for months and months, you had congressional hearings, like what was the underlying cause? How could this happen in the United States? What was going on here? Well, they did get to the bottom of a few key, some of which were, okay, first of all, affordability. If you didn't have health insurance, if you didn't have private health insurance, you probably could not afford to get vaccines or necessarily all the vaccines. So that's a big problem. And then they focused a great deal on the fact that there were missed opportunities to vaccinate. By that, I mean, you have a child who's eligible for a vaccine, comes into your office, has a primary care visit and leaves unvaccinated. What's with that? Well, a big part of it is not having accurate vaccination assessment information at the point of care. And I have to remind you that, okay, we're talking about 1989. That's a long time ago, right? So, the different world. This is office automation in 1989. All right, so no, this is, I mean, it's some, maybe hard for some of you, but
Some people may not know what that is.
okay, I'm about to say, that is a fax machine.
Hmm.
Okay, and today is reigns supreme in many practices as well still. But no cell phones, no internet, right? No internet. How do you live without internet, right? No internet. Really, internet as we know it didn't really come on the scene until about 1995. So no internet, no cell phones, no electronic health record systems. What do we have? Paper. And if we want to talk to another practice, get on the phone. We did have telephones. You get on the phone, you mail letters, you can exchange information through postal mail or fax was the name of the game. So in this world that we're living in, we had a major opportunity for immunization registries, which were not unheard of. They did exist, but in very, very small sort of experimental ways in some communities. And so they were out there, but this was the moment at which there was this huge policy push. And by that, I mean, like all caps, huge. There was an outpouring of funding, like really, rarely seen. This is the golden era of immunization registries because people were so outraged by this. And so Robert Wood Johnson put together what was called the All Kids Count program. I know Gary and Sarah are very familiar with that. They started with 23 sort of pilot registries around the country to see what worked. Nobody knew what was going to work and no idea. And so CDC had tons of money, all caps, bold, tons. This was the golden age of immunization registry funding by the CDC. Other organizations, the National Vaccine Advisory Committee, all got on the bandwagon to say, we must have these registries and we got to fund them now. So from the beginning of the 90s forward, there was just an outpouring for the next decade of funding for registries. At the same time, I'll mention that unrelated to registries was the fact that the beginning under the Clinton administration, we had the Vaccines for Children program. So that allowed children who either in Medicaid, uninsured or underinsured, all would receive free vaccine. So crucial. All right, so just to remind you a little bit about these registries, what they do and why they are so important. Again, we're living in a paper world, folks. So here we have sort of this spoken hub model. In the middle is registry. So private providers, health systems like the University of Michigan, public health agencies, pharmacies, school-based programs, all would submit their information for vaccines administered to the central registry. So it's all going into one central place. Great. Better than that, it's all available back to them all. So if Dr. Freed's seeing a child who happens to have gotten a dose at a local health department, that would be available at that from that one centralized source. So this is a key advantage where you have this comprehensive collection of information and it's population based. So you've got, in a theory, every child or every person in a population, let's say the state of Michigan, and all doses administered to those people. So you have the complete package. It's really, really great. All right, so it's all there. So just to orient you to, the registry here in our state, truly a population-based registry. Since its very beginnings, all births in the state of Michigan go directly into the MICA registry. So within about 2 days, when births are certified, hello world, they're into the registry. 275 kids, infants every morning show up so 275 kids show up in the registry every morning, brand new infants ready to be vaccinated with that Hep B. So Couple key things to know about MICR, which is really sort of this ideal situation. State law requires that all doses be reported to the registry. So for kids, persons under 20 years of age, all those doses have to go in. It's authorized to accept doses for old people like me. So for adults over 20 years of age, those doses can also go into the registry. And then all COVID doses are also must be reported. MICR also tracks things like newborn screening, blood lead testing, and newborn hearing screening results. So it's all there. So with this outpouring of cash, this development of registries all across the country in jurisdictions, large and small, lots of questions start to come up. Like, okay, do these registries even work? I mean, like, can you accurately identify kids who need to be vaccinated? And if so, what are the most effective strategies? How do we know what works, and how do we know how to improve things? And importantly, how do we keep timely, accurate, and complete information? So you're going to hear me talk about that. All right. So with that outpouring of funding from the CDC, tons of it, we have here at CHEAR a series of actually more than 6 cooperative agreements over a 10-year period. I'm going to talk a little bit about those, some particular studies from those. But before I do, I want to talk a little bit about how we conducted those studies. And this is about partnerships, and this is really important. So some of those studies were statewide. So 83 counties in Michigan, we would conduct a study that actually spans the entire state. You'll see some of that today. But a lot of these studies were in specific regions of the state and partnered with the local health departments. And so we would have a partnership, which would be the CDC, Michigan Department of Health and Human Services, and let's say a local health department to conduct a study. In addition, I've got these little dots indicating jurisdictions in which we work with private providers. We have lots and lots of partnerships, dozens of private providers, maybe even hundreds. I really stopped counting. But point there is, with all due respect to Michigan medicine, the state is different than being right here at the mothership. All right, it's different. You got to get out there. You got to see how the rest of the state is lives, so to speak. And it's just different. People are operating on other conditions. So I felt it was very important that we partner with these agencies so we can get out there and actually have work that's meaningful to the rest of the state. So that was a big part of these partnerships. So I'm going to talk about three different studies from the CDC or funded by the CDC that spanned 3 different areas of the state. One is Detroit, and which we'll talk about first. I'll also talk about another one which is aimed at high-risk condition kids receiving flu vaccination. And then lastly, I'll talk about H1N1 vaccinations amongst kids over the entire state. So 3 different perspectives. So as Sarah said, I am from Detroit. This is my hometown, and we start there. So we evaluated a reminder and recall strategy in the Detroit and Wayne County around Detroit area, partnering with those 2 health departments to look at 3 different strategies, age-based strategies, 7-month recall, 12-month reminders, and a 19-month recall. So just to orient you to the language, recalls are notifications that are aimed at bringing kids back in that are overdue. Your milestone has come and gone, you're late. Let's get those kids in there to get them vaccinated. The reminders are preemptive. You have a child who's eligible. They can come in now and receive that dose, or sometimes they're sent in advance of them becoming eligible. So those are the 2 different types of notification that we're working with here. So we did this randomization where we had some kids were going to be notified and their counterparts were not, so we could do this comparison. Really nifty design using the MICR-based system, where we developed actually a way to do that in MICR. These notifications were sent by the local health departments, printed by them using the MICR system, and they sent them out. Okay, so picture of the type of notification generated by MICR, and in case you don't know where Detroit is, that's where it's at. So these notifications, like I said, are aligned with the Advisory Committee on Immunization Practices schedule. So the 7-month is following my little pointer thingy. Oh, look at that. So 7-month following this series of vaccines. So if you haven't gotten it by then, you're late. Likewise, the next one was aimed at 12-month reminders at the outset of a child turning 12 months, looking to remind them about important vaccinations such as measles, first dose of measles. Excuse me. And then lastly, the 19-month recall, which is the end of that primary vaccination series. Kids who are overdue for any of those doses, let's get them in there. So in Detroit and Wayne County, we sent out over the course of a year, 4 different quarterly cycles of reminders and recalls. Over 10,000 kids were included in that study, included in those notifications rather. And so a couple key things. So the first thing is sort of like what didn't happen. Well, we didn't see too much of an effect for the 7-month recall or the 12-month. Basically, the vaccinations between the comparison group and the notification group were almost the same. So it's like, that didn't work. So it suggested, hey, the kids are coming in anyway. If you were a resource constrained health department, which they all are, by the way, you might want to save your money and not do those notifications because they really don't have a big bang for the buck. But we did find an effect, excuse me, and for the 19-month-old group, which we found about a 7% bump. So by sending out those notifications, that group of kids had a 7% higher vaccination rate compared to those that did not receive it. So switching gears, we turned our attention to influenza vaccine. And this time we partnered with 3 health departments on the west side of the state, Kalamazoo, Kent County, and Ottawa County. And in this, we did the same sort of thing where we did a randomized design using MICR. This was aimed at, again, influenza vaccine amongst kids 24 to 60 months, so a slightly different group. We used MICR, I should say, to identify kids with a high-risk condition. I'll talk a little bit about this later, but let it suffice to say that MICR had an indicator, a little flag in there, for kids who were in the Medicaid program who had evidence of a chronic condition that put them at high risk for influenza. There was a notification flag in there that we were able to use to focus these notifications on those kids. So those MICR-based notifications were sent by these 3 to health departments during the period of 2008 and or the flu season for 2008 to 2009. So I'm going to share with you just a super high level result here. So there's a lot of other results we won't be able to get into, but if you could just focus on the kids who were mailed notifications and they were delivered, and I'll explain what that means in a moment, but it's basically that they weren't returned, they were presumed delivered. Those kids had about a, let's say, 6% higher vaccination rate, a little bit of a bump. And the first sign of trouble, though, in some of the studies I'll share with you is this group here. So we have a comparison with a group of kids to whom notifications were mailed, but they came back undeliverable, right? So in order for that notification to be of value to you, you have to receive it. Your parent has to receive it, read it, and say, okay, I'm going to take action. If it doesn't get to where it's going, it has no effect, right? So this is important. We had heard from our Detroit experience that, after a year of doing it, they're going, a lot of these letters are coming back undeliverable. I didn't know about that. And so this sort of opened our eyes, and you'll hear more about it throughout the rest of the talk of the data quality issues, which are really significant barriers. So this group was sort of our first sort of warning sign that maybe the information isn't as great as we want it to be. All right. So what we found out was, I think, some key take-home messages were, okay, while we found evidence that they were effective, you do get a little bump in increase in that population that receives the notifications. A lot of them aren't receiving their intended recipients. So that's bad news. As a matter of fact, for this group, we had introduced the use of something called a National Change of Address file, which is from the Postal Service, which allowed us to actually screen addresses before we even sent out the letters. And we could actually say, hey, well, this is an invalid address. That letter is never going to get there. So we actually could filter those out. Those were filtered out before the letters were sent. That was great. But we did get some that were unrecognizable by the NCOA process, and they got returned and counted as undeliverable by the physical letter itself. So all told, though, 42% of the kids in a population had bad addresses. That's not good, folks. That is really bad. So, and you know, opened a career for data quality looking at Maker, because there's a lot of issues. It's not just Maker, believe me. There's a lot of issues. So we're going to talk more about why that is. All right. So the good news is we did this pilot study for influenza notifications for kids with high risk condition. Great. A year later, the pandemic hits. The other pandemic, the H1, right? This was the warm-up act, right? So this is the H1N1 pandemic of 09 and 10. And we had this, we had already pilot tested the year before the fact that MICR could be used to do these notifications to these high-risk kids. And the state, the Michigan Department of Community Health at the time, was very adamant that they wanted to use that indicator to do a statewide notification. Every kid who had a chronic condition that was marked in MICR, they wanted to notify them. There was a lot of early evidence to suggest that kids with chronic conditions were, being hospitalized at a much, much greater rate and dying also. So this is a big deal. They said, let's just do this. And they did not want to, there was some difficulty in getting that national change of address file for statewide use. We're not going to wait for that. And lastly, this is going to happen right now. We're not going to wait for some groups to be notified like as a control group. There's not going to be any comparisons. We're doing a public health intervention. We're sending them out. They wanted us to work with them to evaluate that. So this was not some classic experimental design where we get to pull the levers and say, this is how it's going to work. That was off the table. So reminders are sent to parents of kids between 6 and 18 years of age. And again, these are kids in Medicaid who have evidence of a chronic condition. So we compared as best as we could those groups who received the notifications in a variety of high risk groups, as well as those that didn't receive it due to the fact that they were undeliverable. So this was a statewide intervention, all 83 counties. The example letters included here was a special letter which was focused on the importance of H1N1 vaccine in addition to the seasonal vaccine, seasonal flu vaccine. So just to focus your attention on a couple of things here. All right, so we found that the notifications had a effect. I would call it what would be polite ways that they'll say modest. That's the right word, modest effect. So this is one of those things where statistically, yeah, it's significant. It's not huge. It's like 2 or 3%. That's not great. So, but it's real. So we have a high risk notification, the reminder group compared to those who did not receive it, their counterparts who had a returned letter. So, you got it and you didn't. We're comparing those two groups. All right. So it's about a 3% bump. Not great, but it's real. And then we also compared to those kids, basically a case control study where we matched non-high risk kids based on birth, month and year and county. All right. So we matched kids. There's 142,000 letters. That's a lot of letters, by the way. Big group, big comparison, but you know what? Tiny effect for the reminder group, and we found, of course, that the no reminder group did not really have that effect at all. So, what did we learn? We learned that when you do these public health evaluations, again, it's not an experimental design. You sort of have to kind of go with what you got, right? So you have to create these comparison groups. We're not necessarily ideal, But it did a couple good things. It did demonstrate that you could use this registry on a statewide basis for this influenza reminder, and it worked. I mean, the system worked, and that's what the state was really interested in knowing. But also, did it work in terms of the effect? Modest. I think that's the right way to say it. It was modest, but the thing that we learned, and this became super important for years and even decades following, is that these undeliverable notifications are a gigantic problem. They're a real problem because if they don't get to who they're intended, there's no effect. There's no possibility of it making a difference. Two things that I should share with you. So we couldn't use the national change of address file. That was not available to us. So we could not filter out bad addresses or correct bad addresses. That was not great. The second thing is it became evident, that's probably the right way to say it, that influenza vaccine doses were not being entered into MICR on a timely basis by providers. So guess what? We're sending lots of letters to kids who have already been vaccinated. That doesn't have any effect, does it? So that's part of what we're seeing in this particular, natural experiment we're observing is that muted effect has a little bit to do with that as well. So I just want you to know about that. I'm going to show you two other studies that look at different facets of barriers, and just to get a little bit further or put a finer point on this. And so one of them is more closely looking at the undeliverables, and the other is looking at something that CDC was interested in, which is why are private provider offices not using MICR to use reminder and recall? Because again, this is in the era of, there's no electronic health record systems. There's no automation in these offices. Why don't they use these computers to do this for them? What is the problem? So we're going to look at that. And I'll tell you what the problem is. So these undeliverables, starting with another study that was in the southwest corner of the state, and partnered with 11 different health departments. We used MICR during the 08-09 time period to do reminder and recall notifications for kids between 6 months and 19 years. We went with those health departments. They said, do notifications using MICR, any age groups you want, whether it be the really young kids, school enterers, adolescents, whatever. So we collected all those results for all those different age groups, and we tracked the undeliverables. This particular study was not aimed at the outcome so much. Well, it was not aimed at the vaccination rate as the outcome. It was aimed at the undeliverables as the outcome. We wanted to understand what groups were particularly affected by this. So all told, there was over 20,000 notifications sent across those 11 jurisdictions. We found that 26% of them came back as undeliverable. Okay, so that's not great. And in this case, 26 came back as physically undeliverable. And this particular study predated our use of this national change of address file. So we didn't really have the benefit of knowing the other ones that were sent out that never got returned. The forwarding address is invalid, and those are gone. So just to give you an image of what that's like, and this is done for many, many studies that we conducted, the familiar, return to sender sticker that the Postal Service puts on there, those are coming back to the health departments. And so we are going around driving to, southwest corner of the state, picking these up periodically. Good friend, Adrian Nichols. So 2010, Adrian Nichols as a student intern, her job, God love her, was to open those envelopes. So she got, Brad has calluses to this day. There we are. She's opening these. What a horrible job. But anyway, why did we do this? Because, okay, we need to know who these kids are. So she'd open the envelopes, flatten out the letter that was in there, and we had a commercial vendor come pick them up, scan them optically so that those addresses were then digitized. And then we could link those back to the mailed notification groups to figure out, okay, this kid did not get it. This kid did get it. So that's how we determined it. So we were able to optically scan those. And here's what we found. So not surprisingly, the younger age groups, these are undeliverables, the proportion of undeliverables for each of these different age groups. The younger age groups, kids between 6 and 18 months or 19 to 35 months, they had some undeliverables, but these are more at the sort of 10 to 12% rate, whereas the older kids, getting up into older kids, adolescents, much higher rate. Makes sense because those younger kids are seeing their primary care doctors frequently, and somebody moves, you update the address, that gets into the system. With next time the kid's vaccinated, it goes to MICR. So it made sense that those addresses were better. They're not perfect, but they're better. Okay. So the last little snippet of a study that I want to show you is with respect to private provider use of MICR. Okay, again, go back through the hands of time. We're working with private provider offices before there really are electronic health record systems. I mean, there are some, a few, but not many. Okay, so this is a paper world we're living in, folks. And so the CDC wanted to know, why are they not using this? Because the automation in the practices would be you sitting down at a computer, dialing up by modem, if you know what that is, using a telephone line to connect to the MICR. This is how we did it, folks. We didn't use tin cans and string. We were beyond. So we were to recruit as many practices as possible to conduct, to use the MICR to do reminder and recall notifications over the course of a year. We wanted to get them to do 4 different cycles. Well, here's their first clue of trouble. So we were able to recruit 20 practices in inner city Detroit and Oakland County. So we're getting a sort of a diversity of practices in the innermost parts of the city out to the sort of wealthy suburbs. Okay, great. 20 practices. How many practices do you think I talked to get to 20? Cute. Here's a clue. A lot. 97. Okay.
Wow.
So 97 practices. Most of them say no thanks. And why is that? It's time consuming. Some of them have already tried. This is a pain in the ass. Now, why is this time consuming? Well, MICR, automated system, is producing your list of kids in your practice that it shows to be are overdue. So you have this roster of patients, but practices don't want to go with just like sending out the letters as is. They want to review those to say, hey, wait, this kid hasn't been here in 5 years. We're not sending letters to these. So they do a manual review. How do you do a manual review? It's on paper. It's all paper. So you got people spending days and days and days reviewing this paper to figure out like who should be in and who should be out. It's very time consuming. So as I said, the goal was to complete 4 different cycles of these recalls for the 19 to 35-month-old kids. Most of these practices have never done it before. So that might have been the clue, right? They've never done it before. They didn't know any better. And so 15 of those practices out of the 20 were still paper-based. So we had 5 that actually had started to switch over to electronic medical records. So that's pretty big news. All right. So what do we find? Good news. 16 successfully completed at least 1 recall. Yay. 9 conducted more than 4, so they actually met the goal. But all of it but 1 reported problems. And by problems, I mean, this is really labor intensive. It took a staff person on average about 2 days to go generate those letters, review them, figure out, no, they're not getting them, this kid's up to date, blah, blah, blah. And they're going through this. And a lot of practices had problems with turnover. So let's say your staff is trained on MICR, but oh, she's on a maternity leave. No, we got to get somebody else trained. Or oh, no, she's not here anymore. We got to get somebody else. This was a major barrier. Actually, 5 of the practices never sent 1 because of that exact problem. They had such bad turnover in some of these practices. So that was a real big deal. But other issues like, oh, well, we're generating recalls, but this kid already has doses and they're not MICR for some reason, or this kid's not eligible yet. So there's a variety of problems that they were identifying and saying, this is just not working for us. It's really, really time consuming. So where does that leave us? Well, medical practices were essentially paper-based. So we have this problem with record scattering. So let's say you have a parent comes in and said, no, I don't, she doesn't need that dose because we got it at the local health department. I was like, okay, mom says that the kid got it at the local health department. That's fine. So you don't administer the dose. Well, you really don't know, and there's no way of verifying it because that is on paper. So a few practices were going to call up the health department, fax over the record. That happened very infrequently. And so you have this record scattering and incomplete information, very, very time consuming. So it'd be like, say, go to those medical records, those paper medical records in your office and try to figure out, like, of the 19-month-old kids, who's really eligible and who's not. It would take you forever. So that is a real problem. One that the registries were aimed at solving, but the incomplete information in the registry was proving to be a real problem. So I'm going to take you on a tour for the next few slides, rolling back the hands of time to the way it was, folks. So you walk in, and some of you worked in practices at that time. You understand what this was. You walk in the door, and what do you see? You see the receptionist and medical records, paper. And when you go down the hall to the provider offices, what do you got? And when you go past that to go to the exam rooms, what do you got? What do you got? More and more and more. And when you run out of room upstairs, where do you go? It's downstairs. You start shoving stuff downstairs and into corners everywhere. So you have paper. So these are not really accessible records, right? It's like, oh, wait, he hasn't been here in about 10 years. Let's see, where's that record at? So that's what I mean by record scattering and sort of the unavailability of information at the point of service. When you need it, at the time you need it, it's very difficult for some of these records to be found. So with that, I've sort of laid the groundwork, I hope, for helping you understand that there are a lot of barriers. So what happened? How do we remove barriers? So here's a slide when you're eating your breakfast later. If you remember one thing from today's talk, this is the slide to remember. This is the most important piece of legislation that occurred in our time aimed at health information technology. Number one. So the High-Tech Act of 2009, it established substantial cash incentives. And by cash incentives, I mean the federal government made available in today's dollars about $41 billion nationally. So it's some real dough. I mean, this is real money incentivizing practices, whether it be private practices, health departments, health systems like the University of Michigan, to get out there and get your electronic health record system. The key, and this is genius, is that we're going to give you, University of Michigan, the money, but everybody who participates in this program has to have a system that is interoperable, which by that I mean electronically can communicate with registries, whether it be immunization or disease reporting registries. So you have to have this seamless electronic connectivity in your electronic health record system. If you have a system that does that and some other basic capabilities, we'll give you the cash. And so that's actually how University of Michigan got Epic in 2012. It's exactly how, and it all across the country, it transformed absolutely the United States. So a big deal. So how does that work? Well, we have the electronic messaging standard that allows that interoperability between these systems is known as Health Level 7, HL7 more typically. This is not a new thing. It's been around for 45, maybe even 50 years. It's used globally. This is a standard messaging for electronic exchange of health data, okay? And by that, I mean reporting to not only immunization registries, but things like disease registries, reporting or lab orders, e-prescribing. All that is done through HL7 messaging. So for our purposes today, this allows us to do real-time reporting for immunization registries, but importantly, query. So it's this bi-directional interoperability. Huge thing. Why is it huge? It took us out of the Stone Age, folks. So what we have is the time that I'm covering today is like, okay, the 1990s, okay, immunization registries roll out. And now we start to get a little bit of attraction with those registries becoming populated, right? We're getting kids and adults in those registries. We're getting their doses. They're becoming complete systems. We can rely on them. But they're oftentimes incomplete. So once we get into this era of the 2010s where we're getting this meaningful use program, as it was called under the High Tech Act, we are getting electronic health record systems almost everywhere, not quite everywhere, but almost. Okay. And those record systems are interoperable, leading us to where we are today. We have these fully functional interoperable systems that talk to each other. It's a huge, huge thing. Why? You can have the information where you need it, when you need it. It's at the point of service. You have your staff trained on Epic. They understand how to pull up patient records. And guess what? That record can have complete, accurate, and timely information there at the point of service because your Epic system can talk to MICR and instantly pull down the dose that I got at Walgreens or the ones that I got at the health department. Those come right into the provider's office when you need it. So it avoids duplication of entry. So they don't have to key that stuff in. And you don't have to train your staff. They're just using Epic. They're not using MICR, they're using Epic. So this is a huge, huge thing. And it's complete in your native EHR. I think that's so cool. All right. And better yet, patient information is typically verified. So in today's workflow, I walk in the door, gee, are you still at 123 Main Street? Yes. Is your phone number still whatever? All that is checked the moment you walk in the door. That goes right into the EHR. Guess what? When your dose goes to MICR, it's taking that new information with it. So that's a big, big deal. That allows not only to have complete information in your EHR, but if you wish at your practice or at the University of Michigan, wherever, you can use whatever the preferred method of contact would be, whether it be patient portals, emails, texting, auto dialers, whatever those are from your system. You no longer have to rely on those pieces of paper being sent by MICR. So this is a big, big step forward. All right. So where does that take us? Well, so for the next decade, so I'm gonna smish a decade into one slide here. So we did a lot of work talking to practices about their willingness to shift from postal mail reminders to electronic or the adoption of email notifications, looking at patient portal use, and then also looking at how that electronic exchange and interoperability was affecting clinical practice. So what were the advantages and were there any barriers in terms of time or expense? So all of that occurred in the ensuing 10 years. All right. So where that brought us to is sort of the current era, which as the electronic health records rolled out and this electronic interoperability occurred, the Department of Health and Human Services MICR program was very interested in understanding the data quality changes because of that. So we started in 2011 working with the MICR team here in Michigan. So it's now almost 15 years of providing data and analytics support, looking at MICR data, timeliness, completeness, accuracy, and then also doing related studies and analytic support, epidemiological support, and so forth for the MICR folks. That has sort of morphed into a similar set of support for the blood lead program for the state of Michigan, which also can receive blood lead results from laboratories by HL7 messaging. So we have for 10 years provided that support to the blood lead program. So with that, I'm going to shift from the registry discussion and just to finish up with a little discussion here about chronic disease surveillance. And then if I have the time at the end, I'll talk about some synergies between the two. So as Sarah Clark outlined a few weeks back, our partnership with the Michigan Department of Health and Human Services and Medicaid program, it's really foundational to our center. A big part of that, which was really exciting, Sarah and I were talking about before we started here today, the data warehouse. This is, at the time, really novel and unique that the Michigan Medicaid program had this centralized data repository that you could reach into and pull out information on beneficiaries, enrollment and eligibility and their administrative claims. Very few states had this, okay? And even in our state, there weren't a lot of people who were using it except the
the actuarial people within the Medicaid program. So when the partnership with the Medicaid program started with CHEAR, they were very pleased to have us help them tap into that information as we were doing the evaluations that they asked us to do. So this was a very unique and important opportunity that we were able to tap into. And I was talking to Gary. I'm not actually sure that we knew what we were getting into at the time, but you know, Gary just nodded his head and say, "Okay, yeah, we can do that." So we did it, and the "we" was me, by the way. So. So I learned a lot about stats programming in the data warehouse. So yeah, doing all that stuff. So one project that we conducted, which I won't get into the details other than one thing, they had asked us at one point early on, and this is like 2001, 2002, to help them figure out why there's such high levels of emergency department use by kids. Like, what's going on? There's these frequent flyers and they're coming back. Like, what is going on? Well, it turns out that we discovered that asthma was actually the leading cause of non-complex emergency department use. So that's one little tidbit that we found from that. That actually led to a much bigger sort of thing. So that was important, but hold that thought. It's like, well, the chronic disease epidemiology folks at the department were also interested, you know, could we use those claims to look at the population level for the state of Michigan and come up with a way of monitoring prevalence? It's like, well, we got the denominator and we got the numerator. Yeah, I guess we could do that, right? So we collaborated with the state on developing what I'm terming a HEDIS-like strategy, which HEDIS, if you're not familiar with, is the Healthcare Effectiveness Data and Information Set. It's a health plan quality measurement program, which is used by not all, but pretty close to all health plans in the United States. This is a big deal, okay, if you don't know about it. But there was a method that they had for identifying asthma cases that we thought, well, we could pattern something similar off of that and apply it to the state Medicaid population. So there's about 5 years of work in that one bullet. And so we did it, we demonstrated it, we validated it. It's all there. So it's like, okay, this works. And so this is a really, really big deal. And it truly was a novel thing. It was not being done very many places. I think California had just started doing some Medi-Cal, their Medicaid program for their health plans looking at asthma. But it was just like little snippets there. So the cool thing about this, and important thing, not only cool, but important, is that you have a statewide look at a population, denominator, numerator, the whole shebang for the whole state. And better than that, not only can you come up with the proportion, 8% of kids have asthma in the state of Michigan, or severe asthma, or whatever you're looking at, but you can link those individuals to their health services. Well, why is this child a frequent flyer? What's going on? Are they on the appropriate medicine? It can all be revealed. And so for the next 10 years, we looked at exactly that. And so not only looking at the epidemiology of asthma, partnering with folks here, Toby Lewis, I don't know if you're here online. Hi, Toby. So lots and lots of work putting a finer point on the epidemiology, but tons of work on the appropriate medication use. Looking at high flyers, frequent flyers in the emergency department, going back upstream. Are they just using short-acting beta agonists, the rescue meds, instead of the long-term controllers? Like, what is going on here? So we were able to look at that. And Sarah Clark and I would make frequent trips to Lansing to meet with the what was called the Clinical Advisory Committee. And those were, 15 health plans, Sarah? We would present results such as these. And first of all, they were aghast. They're going like that. I can't believe that there's such high rates, whatever. And it's like, it's actually your data, right? So we're looking at their data. They had no idea how to do that, but they were very interested in it. And we also looked at other things like, influenza vaccination and some other things. So since you're dying to know the details, there's the footnotes for you. I've got all the citations at the end, but we spent a ton of time doing that. But importantly, and especially importantly to some people in this room, this served as the groundwork, this method of taking administrative claims, in this case for asthma. Why not use other chronic diseases and apply it there? And we did. So for sickle cell disease, talked to Sarah Reeves about that. inflammatory bowel disease. Jeremy and others have demonstrated that, and it's also been applied in chronic kidney disease as well. So this basic method has some legs. It actually can be applied in other ways, which is a huge, huge outcome of that. So I just have a few minutes left. I'm going to just talk about synergies. And by that, I mean ways in which some of this information has come together. I've already told you sort of in advance and out of order that that chronic disease epidemiology work actually was applied to MICR years before. Okay, that's how we did the high risk indicator. That is exactly where it came from. So that was allowed us to find kids with more than one claim for any high risk condition, which was considered to be from the list published by the CDC, any chronic condition. We'd go into the claims, find those, and give that kid an indicator in MICR that they were a high risk case. That's exactly how that was done. Q-metric. Oh my gosh, Gary, look at that. 10 years in one slide right here. So for the Q-metric veterans in the room, and there are several, we used methods, some of which came directly from what I just showed you, to look at some of the quality gaps for healthcare delivered to kids. Most of that was focused on quality measures for such things as asthma and sickle cell disease, but some of those measures were actually endorsed at the highest level of scrutiny in the United States by the National Quality Forum. So this is a really, really big deal. So those methods that I shared with you about administrative claims have actually been generalized to other applications, and Q-metric was one of the projects which benefited from that. Another sort of collaborative effort that we're actually still currently working on that benefits from not so much the administrative claims surveillance, but really more the linking of data sources across different Department of Health and Human Services databases is the Flint Registry. As you know, 2014 and 15, the Flint municipal water was switched for a year to the Flint River. Ensuing high levels of lead in the municipal water caused a real crisis. So we've been working with Michigan State University, which has built the Flint Registry, to help that team from the beginning to actually evaluate different aspects of it, starting with the enrollment. We used MICR, and by we I mean Hannah Peng, MICR, Medicaid, vital records, births and deaths to identify persons who are potentially eligible to be enrolled. And then likewise, we used other data such as vital records to look at different priority groups, found persons who were exposed in utero, babies being carried by mom who were born later. We found their birth certificates and looked upstream to see moms who lived in Flint. That was pretty cool. And then also did some other linkages, but all of those kinds of linkages were based on the foundational work for our work with the Michigan Department of Health and Human Services. So the last thing I'm going to talk about, the very last thing, and then we're at time, is something I'm very proud of, which is the Population Health Informatics course that I created in 2013, taught for 7 years. That was at the request of the School of Public Health and School of Information. It was primarily aimed at graduate students in the Health Informatics program and Masters of Public Health program that were getting a certificate in health informatics. Covers all levels of skill building for like what I would refer to as real world, like linkages, because registries are messy and they don't have natural linkages between them. Teaching students how to do that, all the data standards necessary to do that, and put together a course that covered all the bases. So with that, folks, there we go. Want to put that picture of two old dogs walking into the sunset.
Evan, thank you for, go ahead. I just want to say one thing, that what should be obvious to all of y'all after this is that many of the things that today we take for that we can do with regard to EMRs and the use of health information or linkages would not have happened without Kevin. And it's very easy for us now, especially people who are just starting out, to say, oh, great, I can take this here and I can take that there and this works. This, you're able to do that because of what Kevin has accomplished. And it's just really extraordinary that one person has had that kind of an impact. And I just want to say,
have a few small tokens of our appreciation of your amazing career. The first is this chair.
You anticipate I'll be doing some sitting.
You're very proud.
Sure. And then the other thing is that we do have a cake in the kitchen that we will, I encourage everybody to gather at around noontime for us to cut the cake and enjoy it. So
Well, thank you. I'll be sitting there cutting cake.
And autographs.
So I did not leave much time for a question, but I just want you at some point to connect with Sarah Clark on the real story about the Detroit Health Department parent focus groups. Right, so that was part of our Detroit side. There is sort of the untold story of knowledge, attitudes, and beliefs that Sarah was gathering from parents.